Alright everybody, so this is going to be as brief of a PowerPoint as I can make it. It's pretty long slides. So surgery, we know we can do that to diagnose, cure, prevent, do a look and see what's going on. Can even be cosmetic. There's three parts of the surgery. It's the preoperative, before surgery, intraoperative, during, and then postoperative, which is afterwards, in which case the patients generally go to PACU, which is post-anesthesia care unit. Nowadays, most surgeries are actually done on an outpatient basis and have surgery and then go home that same day. Even my knee replacement was happened with that. Preoperative clearance. So depending on the type of surgery, how complex it is, how risky it is, will determine like what types of tests that there needs to be. So the primary healthcare provider is going to order the test appropriately. The nurse, RN, is responsible that if you're getting ready for surgery, getting somebody ready for surgery, and you see a lab is not normal, then that is your responsibility to call. And we'll go into some of those examples in class specifically. So common tests, EKGs, right? We're going to do that very frequently. Pulmonary function test, maybe only if they have a lung issue. SpO2, everybody. ABG, only for specific things. Like we used to do them pretty routinely before somebody went to open heart. I'm not sure if they're even doing that as much now. Chemistries and the CBCs, those are going to be done very routinely for most procedures. Probably not our cataracts that are just done at like a doctor's surgery center. But anything else, we're looking at more like that'll be done. Liver function tests may not be all that expected unless there's something wrong with the patient. Pregnancy tests are very common for somebody who's of childbearing age. The PT, PTT, INR, those are going to be bleeding risks, so that's pretty common. We're going to be cutting somebody open. Albumin, we're going to talk more about that when we start talking about electrolytes, but that's our protein in our blood, so it's not going to necessarily be common for all surgeries. Type and cross match, if we think they're at a risk for bleeding, we're going to go ahead and have them typed so it's easier to get the blood. And then urinalysis is pretty common for a lot of surgeries these days. So preoperative period, things that we're going to do a very detailed head-to-toe assessment. So we're going to, ask all about all their history, ask about their assessment. Big things not to forget about is that psychosocial. So if you have somebody who is having double mastectomy, you can imagine that as a woman, they may no longer feel like a woman. They may be worried about their significant other's reaction to the surgery, to the scars. So that can be a thing. And just going under surgery, just being put to sleep, people are afraid, maybe I won't wake up. Assess for latex allergies. This is a really big one. So there's a list of foods in your textbook. Some of the big ones are avocado, banana, kiwi, chestnuts. Sulfa is also on there. If you have those allergies, you're at a higher risk for having a latex sensitivity or a latex allergy. And that's a really big deal. If you have a latex allergy, they have to prep that OR room completely different, and that can be like an extra 20-minute setup. So if you find out somebody has a latex allergy, you're going to want to let the OR know right away if that was not found out. Or if I find out, hey, they just told me they're allergic to kiwi, so you guys need to prep for, a latex allergy. Family history of somebody having problems with the anesthesia. And so this is the risk for having problems with malignant hyperthermia. And so succinylcholine is one of the anesthetic medications that is used to help put somebody to sleep. And that medication, somebody can have that malignant hyperthermia. So with that, we're going to ask about family history because there is a genetic component to that. And then, of course, medications. We want to make sure that they stopped aspirin if they were on aspirin. Vitamin E, ginkgo, all of those things actually cause increased risk for bleeding. NSAID, so if they're taking ibuprofen or warfarin, all those things, they're told when they're supposed to stop those. And depending on the surgery, the risk factors, those may vary a little bit. We also want to make sure that they're not going to have withdrawal from other things. So in the preoperative period, again, this is just some of the examples of some of the things that you would ask from that very thorough assessment. I'm not going to read this to you. I trust that you guys know how to do a good assessment. So we're going to move to the next part of the assessment. Again, here, this is just continuing with the GU, hepatic, and tegumentary. Again, on here, not something that really, none of that surprises me there. Pardon me. Musculoskeletal, endocrine, again, those are things that we'll be asking, again, part of that assessment. And we continue through immune, gastrointestinal. Remember that somebody who is overweight, they have an increased risk for dehiscence, which we'll be talking about later in this PowerPoint. They have a slower recovery from anesthesia, and they could have slower wound healing. So preoperative teaching is really important. We want to teach somebody before they've actually undergone the anesthesia. They're more likely to remember it. Now, we're going to reinforce it postoperatively too, but we want to make sure that, we're telling them what to expect. So, for example, if I have somebody who's going for open heart, I'm going to tell them that they're going to have a tube down their throat breathing for them when they wake up. And that might be scary, that they're not going to be able to talk. I'm going to tell them that they're going to have tubes coming out of their chest. They're going to have a urinary catheter. So I'm going to let them know all of those expectations of kind of what the progress is going to be. Now, the healthcare provider should have already done that. But again, telling them ahead of time is really important. We also are going to teach that coughing and deep breathing, early ambulation, if it's appropriate. Pain medication, so making sure they know how to use that pain rating scale. I already mentioned about the tubes and drains. Let them know if they're going to be NPO or if they're going to have an NG dropped. And then making sure that we're keeping appropriate people informed, the caregiver who's going to take care of them. As long as the patient's okay with that, we would include them in that education also. Legal preparation, so for somebody who's going for surgery, of course, there's an informed consent. It's an acknowledgement of informed consent. So most of the places where I've worked, I'm not allowed to actually get the consent. However, the forms that I've seen, it's an acknowledgement of informed consent saying that, yes, the healthcare provider has provided the education. They don't have any questions. And then the name of the procedure is very clearly written on there. And you can never use an abbreviation. You can't do an R when it has to be written out for right or left if there's a designation. We always want to make sure that any power of attorney, advanced directives, we know what they want. Of course, that consent for surgery, I already said, we're getting that clearly, voluntarily. And then ultimately, as I said, the surgeon's responsible for obtaining the consent, but we may witness that signature saying that it's an acknowledgement of informed consent. Day of surgery, so we're going to double check all those lab results, make sure everything's okay. We're going to make sure that H&P is done, the history and physical. Consults are done. We have baseline vitals, proper skin preparation, so we may shave the site, or somebody else does. It's never been me. It's always been a surgical tech. They might shave the site, then there's special cleaning that they would do. There's an actual pre-op checklist, and there's a nice example of this in your textbook, and the nurse does that checklist. And when you do the checklist, make sure you read line by line out the patient. Don't just do it in your head, this is done, this is done. You want to ask. You don't have any jewelry on it. I don't know. You don't have whatever the case may be. You're usually not allowed to send them with anything on except for the hospital gown. Not any underwear, panties. I know a lot of people hate to wear panties. Socks, literally nothing but the gown. Cosmetics, that should be taken off. And then we don't want any nail polish on because it can change our oxygen sensors. And actually blue's worse than red, but we still don't want them to use anything. So valuables, we usually try to send that to family or we lock them up. Always want to make sure that they urinate prior to going, and we want to make sure they urinate before we give them any sedatives, right? So that they don't have any problems with falling. Preoperative medication, so it could be the benzodiazepines, alprazolam, diazepam, anticholinergics that are going to help dry up the mouth. And if you remember from class, anticholinergics, the side effects of that is, you remember, can't pee, can't see, can't spit, what rhymes with spit. Opioids, we talked about that in class the other day. Antiemetics such as ondansetron, promethazine, and then antibiotics. We're going to talk a little bit more of that in detail here. So transportation to the OR, they're usually going to go by stretcher. In most of my example, UAP or transport, it does not have to be an RN taking them to surgery unless there's a specific case. We're not learning those things at this point, so we'll consider that a non-issue. We would give our typical handoff report. And nowadays, nurses come up sometimes and take it, so the nurse gives nurse-to-nurse report, which is nice. All right, so we're going to do a case study in class. So here I'm just going to move on through that PowerPoint. So the OR holding area, when they're getting somebody ready, final questions, we're going to make sure about the last food. And we'll ask specifically, when was the last food versus when was the last water? Because they might have taken a pill that they were allowed to take with that. Make sure that all preoperative drugs are given and the patient's hair is covered. So in the OR, the big thing is there's so many risks in the OR, just lots and lots of them. So musculoskeletal alignment, and they actually put like pads on the bony prominences so that there's not any nerve damages, making sure that we're keeping them covered until we absolutely have to have things showing. And then we want to make sure that, there's not any injury to them from that. Skip, now this is really important. Hopefully you are somewhat familiar with this, is surgical care improvement projects. So these are three things you need to know. That SCIP projects, these are our evidence-based practice in action. So with our evidence-based practice, they need to have the antibiotics started within 30 to 60 minutes. So that's before the surgical incision. So what that means as a nurse for me who works on a floor is I'm usually going to have my antibiotic ready and primed, but not turned on. I haven't actually hooked it to their IV tubing, but it's up there. I haven't scanned it because I'm not the one actually giving that. So I have it ready and I send it to the OR because they're going to decide. Maybe there's a delay with the surgeon getting there, or maybe there's a delay with something. And so they're actually going to start that antibiotic exactly 30 to 60 minutes before that incision. We also apply a warming blanket to prevent hypothermia. I've seen the bear huggers use. So it's like it blows warm air on them. So it's not just a warm blanket out of a warmer. This blows continuous warm air, and that's to prevent that hypothermia. And then they put the pneumatic compression devices, also known as SCDs. Those are the pumps that blow up gradually to risk for venous thromboembolism. So these are three things that I absolutely want you to know that are included in the SCIP project. Timeout Universal Protocol. So this is one of the National Patient Safety Goals. Again, this is evidence-based practice that before they have anesthesia, we're going to confirm the name, date of birth, procedure, the site, the consent, and the patient has to be able to verbalize these things. What are you having? What is doing it? Who's doing it? All those things. And all members of the OR team just stop everything. They literally stop and they double check that it's the right patient, right body part, right procedure, everything. So, and that's because, you've heard about the wrong limbs being amputated. Can you imagine waking up expecting your left leg was going to be amputated and your right leg's been amputated? And now you're going to have to go back to surgery and not have your left leg amputated. I just can't even imagine. Yeah. Physical, emotional pain, everything. So catastrophic events in the OR, anaphylactic reaction. So anesthetic agents can cause problems. Obviously, antibiotics, we know there can be anaphylaxis. Latex, there can be really bad reactions. So we have to really be watching for those and then making sure that we're changing things quickly. So if we're talking about anaphylaxis, that's going to be hypotension, tachycardia, bronchospasm, pulmonary edema. So we'd be watching for those things that were related to anaphylaxis. Other potential events is that malignant hyperthermia, which I mentioned. It's really rare, but it's really deadly if it happens. So the most important thing is a good family history about, does anybody in your family have problems with anesthesia? Again, I told you that succinylcholine is the primary trigger. It is a genetic issue. So signs of malignant hyperthermia, skeletal muscle rigidity, tachycardia, tachypnea, hypercarbia. And hypercarbia is just a fancy name for saying high CO2. And so remember when we talked about PCAs and high CO2? What's interesting, here we're saying the patient is breathing fast, but their CO2 is rising. Those two don't go together. Remember, if somebody is breathing slow, the CO2 rises. So this person's going to have an elevated respiratory rate as well as an elevated CO2, and that's a complete mismatch. That shouldn't be happening. That should be like a big what's going on. We also have that risk for cardiac dysrhythmias, and then really high rise in body temperature. We're talking about 102s, 103s, but that's a late sign. We're not waiting for that sign, or else the patient's going to have a potential problem. Dantrolene, this is a medication that we would give in suspected malignant hypothermia. We're also going to cool the patient, and if they have any acid-base imbalances because of that hypercarbia that I mentioned, we're going to try and fix those things too. So on this slide, I do want you to be aware of the medication succinylcholine, which is right here. And again, that dantrolene is the medication that we use to help with that catastrophic event. All right, so we're going to again skip that slide. Postoperative assessment. So PACU. Remember, the number one thing we're doing for somebody from surgery is airway. Airway, airway, airway. I mean, airway's always the right answer for almost anything else, but especially for PACU. Now, this is different than actually on the floor. In PACU, airway is our biggest thing. Then obviously we're looking at the breathing, our normal breathing things, respiratory rate. Do they need oxygen? Do they need the capnography because maybe they have a PCA? And then circulation. And then postoperative assessment, neurological, checking to see that they're doing okay with that. Genitourinary, are they putting a urine out? What was their EBL? That's estimated blood loss. And the OR will report that to the PACU nurse so that they're aware whether they're at a higher risk for circulatory issues. Bowel sounds at the NG, they're going to be checking that. Surgical site. So, in here it's kind of going in a very specific order. My personal thing is I'm assessing airway, breathing, checking my vitals, and then I'm doing a focused assessment on that surgical area first, and then I kind of go back around and check and make sure the rest of the assessment is good. Remember with surgical site, usually they're going to have a dressing on there, and if there's any drainage, we actually just draw around it and time it. So that way, if it gets bigger, we actually know quantifiably like it has gotten bigger. With dressing also, remember to listen, look underneath of them. So if they've got an abdominal incision, it can pull behind them. So always look under the patient and make sure that there isn't any bleeding there too. Discharge from the PACU, so they have to be awake or at their baseline or what's appropriate. If they, had open heart surgery, it's going to be different. No excessive bleeding, no respiratory depression. Their saturation has to be greater than that 92. They should be in pain management, unlike my story with my hysterectomy. Nausea and vomiting should be controlled, and then they give report to the floor. Or they leave the PACU, they'll go back to like a same-day surgery area. So this is just some of the showing you where can be the different complications from this. I'm not going to read this slide to you, though this is from your textbook. This is really good to kind of look and make sure you understand any of these. If you don't understand any of these complications, then let me know. And we'll be talking about dehiscence and all of that a little bit further on. All right, so postoperative interventions, making sure that they are in the proper patient positioning. If you have somebody who is not conscious, they might put them in this lateral recovery position because that helps with airway and drainage and that. As soon as we can, we're going to want to do coughing and deep breathing and a sinus barometer. Abdominal incisions, we give them a pillow to help splint it. Chest, like open hearts, we actually have a little heart pillow that they hold on their chest when they cough. IS and sinus barometer, depending on it, it's usually 10 breaths every hour while awake with a good cough. We want them to be turning themselves in the bed. If they can't do that, we're going to help them. Early mobilization if it's okay. Pain management as appropriate for their surgery. And then adequate hydration, either parenteral or oral, depending again on what they're allowed to have. So other interventions, we're going to be monitoring vital signs frequently, blood pressure, assessing for bleeding, again, checking up under them, TED hose or the sequential compression devices, and intermittent pneumatic compression devices, they're also called SCDs, checking our neuro assessment, and then frequent pain checks, especially with the PCA or if they have an epidural. Temperature, I have had patients come out of the PACU to me, and the one patient I had, actually, as I was checking their temperature, it was going down. And I tried oral, I tried axillary, I even tried rectal. And so this temperature was dropping. The PACU had only checked the temperature one time. And so we did get one of these things. I had added this picture on here. This is like an example of a bear hugger. And so you can see that it's blowing up, and put that over the patient. I had to get an order for that, of course, and get that so that I could actively warm my patient up. So that would be considered active. Passive warming would be just using like warmed blankets out of the little things, little heaters that we have on the floors. Sometimes they have reflective blankets, and then limiting that skin exposure. GI, again, we're going to be assessing for that. One of the big things for all of my patients is after they've had surgery is asking if they're passing gas. Because they'll usually pass gas before they're actually having a bowel movement. And so if they're passing gas, then I know that they don't have an ileus or a paralytic ileus in their belly. And so that's really important so that we don't end up with any bowel complications. They have belly surgery, their hands are all in there. It just kind of slows everything down, plus the anesthesia, plus the pain medicine, just a lot of risk for bowel issues. So really good belly assessment is important on our post-op patients. Obviously monitoring our urine output, intake and output. We want to take that catheter out as quickly as possible because of those surgical prevention things, about bladder catheters, straight cathing, making sure the dressing's dry and intact. The one thing on a brand new post-op surgery, the general rule of thumb is do not change that dressing without the surgeon's blessing. So if it's bleeding through, and it needs to be changed, I'm not changing it. I'm going to add another dressing on top of it and call the surgeon. We're not allowed to take that initial dressing off without their blessing. They want to see their incision beforehand. They want to keep it covered up. And I have had to reinforce the dressing. And then of course somebody had to come and see my patient for that situation. All right, and the rest of these are some NCLEX questions here. We're going to skip those NCLEX questions because we'll do them together. So wound dehiscence and evisceration. So wound dehiscence is this picture here where things have come apart. We talked about that obesity is a problem. And so this tissue here is actually nice and beefy red, that nice pink color. That's actually good. The parts where it's not is not healthy tissue, so that's potentially a problem. And then over here is evisceration, where it's actually come out of the incision. Houston, we have a problem. So with evisceration, the big thing you're going to do is you're going to put warm, moist saline over it. It's obviously a call to the healthcare provider right away, but we've got to keep that tissue moist. So you're going to take saline and put that over that, keep it wet, put a dressing on it, and you're going to call for help right away. Dehiscence, you're going to notify somebody also. Because it's just tissue like that, I don't necessarily need to put warm saline on it. Evisceration, I definitely do. So healing, so there's different types of healing. There is primary intention where we actually put like Everything is pulled together nicely. So that's this picture here. There's that incision. We put a suture there and it's stayed together and the scar looks fine. Secondary intention means that it's left open. So it's open here. They haven't stitched it and it's going to heal by itself feeling in. And so frequently with those types of things, this granulation tissue goes through. With those type of things, we might be doing a wet to moist or wet to dry dressing. And then tertiary intention, this is by delayed closure. So when a wound is initially left open and we're getting some of the granulation tissue, and they may have to do debridement, so they're actually taking out necrotic or unhealthy tissue, and then they close it after they've gotten rid of it. So after all non-viable tissue, necrotic tissue, then they would close it. And this is something you should know, the difference between primary, secondary, and tertiary. All right, so healthcare associated infections, standard precautions, isolation precautions, health acquired infections, is one of those risk factors. So we can get it from endogenous, means just naturally already on the patient, or exogenous, means from healthcare providers not washing their hands very well, or implants. CLABSI, that's when we get the central line associated. CAUTI, that's when we want to get that fully out. Surgical site infections, and then ventilator associated pneumonia when somebody who's been intubated is a risk. All right, let's see, go back here. And then the clean hands, hopefully you remember that when you have somebody who has C. difficile, they're in that contact plus, so you absolutely have to wash your hands with soap and water when you take care of somebody. Hand hygiene is really, really important, and we need to make sure that patients and visitors and even the healthcare providers, everybody is washing their hands to help keep them from getting infections. So I hope this is helpful. We'll talk more in detail in class, and thanks so much for watching.